Hi, everybody. This is Kevin with Garrison Dental, and the smiling face you see at the top of your screen is Dr. Jared Johnson. He's live with us from out in Iowa. Kendall and I, of course, are here in West Michigan. So it's the wonders of technology bring us all together here this evening, and we're expecting a pretty big crowd of folks here tonight. So I'm going to go ahead and get rolling on some of the details here so that we can give Dr. Johnson as much time as possible here tonight. So tonight's course is on sealants, and it is an AGD PACE course. And as such, we have to send you at the end of the evening, we'll send you a course evaluation and quiz. Both of those have to be completed in full, and when you hit the submit button, that'll come into our system, and our system will turn around and send you a CE course attendance verification certificate. And when you're filling out your eval, there is a spot on there if you're an AGD member to put your 6-digit AGD member number. Be sure to do that, and we'll go ahead and submit that to the AGD on your behalf. Now, if you don't get the evaluation or you don't get your quiz or any of that kind of stuff, please use that webinar at garrisondental.com email address. That's the address that will get you the fastest service if you've got any issues like that. And I think we should have time this evening when we're done with the actual presentation. We should hopefully have a little bit of time for questions at the end. And like we typically do, Kendall will help curate those questions at the end. This is, of course, sponsored by Garrison, but tonight we have a co-sponsor with SDI. They've got some wonderful materials, and Dr. Johnson, I think, is covering some of those materials in tonight's course. So glad to have the SDI folks helping us out with this course here this evening as well. So without any further ado, I'm going to go ahead and turn things over to you, Dr. Johnson.
Well, thank you, Kevin. It's really a pleasure to be with you tonight. I really appreciate Garrison Dental. You guys have been a big supporter of just pushing dentistry forward. And I'm not talking really much about any of the Garrison products. I do use them at my office, and they're great, but they really want to bring you top quality education. And Kevin has really gone and sought out that, and we've built relationships. And those relationships that you build with people, whether it's your patients or someone you work with, are very important. And I really value that, Kevin, and I thank you for bringing me to come on and talk to all your clients about something that's so important. That's prevention. We don't talk about prevention enough, and right now in dentistry, we're kind of riding this new wave of the medical model for caries treatment. And that is something that is going to take a lot of our traditional values and challenge them. It's not an easy conversation by any means. I think it's the right conversation for our patients, but we're also figuring out which types of patients can benefit from this treatment, because it's not an easy thing to do to determine who can have something minimally invasive and who can't, because we're all at a different risk for developing decay. And sealants play a huge role into that. And I've been challenged with this at my office in determining what type of sealant to place when, who to place it on. And this evidence I'm going to present tonight, it's evolving. It's not going to be the tried and true of 10 years from now, but what we have is what we have to go upon. And I think we can come to a good model. If you want to do resin sealants, great. If you want to do glass ionomer sealants, great, but let's do them the right way and understand the bonding, the technology, and all of that. And I'm really excited to move into that tonight. Like Kevin said, I practice in Muscatine, Iowa. I'm a pediatric dentist. Do have to disclose tonight that I have received financial support for tonight from Garrison Dental as well as SDI, and I use their products. I am not one to lecture on a product I don't use. You're going to get me for me. I am the practical pediatric dentist. If there is a product on the market that I'm not using, I'm not going to lecture on it. So everything you see tonight, I'm going to present data from my office, from the ADA that has pulled out data from my office with Open Dental on my sealant placement. I went to a lecture once and someone gave me the comment back that I was providing substandard care to my patients. And why would I come and teach all of you how to hurt kids? That's not what I'm here for. I'm here to move things forward. And I'm excited to do that, whatever way you want to do that tonight. Also, if you want to follow me on Instagram, I'm Dr. Double J's. I share my failures. I'm very practical. That's how I learn. I get better from not doing things right. And if you want to learn some things from me, from what I've done wrong or what other dentists have sent me that has gone not the way we wanted it to happen, we're not perfect 100% of the time. And I'm not perfect 100% of the time. So understand, give yourself some self-love, some self-compassion when things don't work out. But also, when you have that patient come back that was difficult in a difficult case and it works out, celebrate that, because you don't always look at your own work and see the class 2 that's routine, but it worked out. That is a celebration. Don't forget that in your life. You'll be a much better dentist for it and be much happier with imposter syndrome. The outline tonight, we're going to talk about the problem, which is obviously occlusal decay and buccolingual decay. We'll talk about materials, what materials are out there, what the evidence is, and the techniques. Isolation, if you want to use cotton rolls, isolate, or isodry or rubber dam. Tooth preparation, bonding, that comes into play. Big factor in, especially if you're sealing over decay. I know that might be a little passe, but that's the medical management model that's going on in Europe right now. A lot of evidence coming out on that. Air abrasion, if you do a cleaning before or not. And then we have some clinical questions. I know we all have that take that these school-based sealant programs are not good, and I don't think that's true. I don't think it's a school-based sealant program. I think it's the provider. There's different levels of providers, and there's a right way to do sealants and a wrong way. And tonight, I want you to come away with the right way, whether you're doing resin, GI, or Comprimer or RMGI sealants. I think you can master this and figure out what works in your office. I figure out what works for me, for my patient flow. And there also are some circumstantial things right now that we're going through with not everyone can hire hygienists. So how do you place sealants? If a hygienist normally does it in your office and you're short, how can you maybe utilize GI sealants for a little bit until you can get back to scheduling that with your hygienist? Because you can do those same day in just a few minutes. And it really is a developing conversation that you need to consider what you're using at your office, consider the options. I would much rather treat a kid with cavities in my chair than do sealants on a kid. And the glass ionomer sealants do allow me to go ahead and place at the hygiene visit 4 sealants in just a few minutes and not have to schedule that patient back when I don't have a hygienist. So keep that in mind. We have to be practical. We can't just put everyone into one corner, one way 100% of the time. And that's why the AAPD has come up with just guidelines. They're recommendations, but there's some times where things don't meet the guideline, and that's okay. And we have to be comfortable with that. When we look at sealants, the biggest benefit, these have mostly been studied in kids, and the biggest benefit is in posterior teeth in kids, because we know about 90% of posterior decay is on the occlusal surface or pit and fissures on these teeth. And that's why insurance covers this so heavily. And we'll get into the data on why they cover it, because it reduces the need for the restoration or the likelihood of the need of restoration of that tooth. If we look at primary teeth, we have about 44% of decay occurs in the pits and fissures, not as much, but there's still a benefit there. And the problem with reimbursement is that when you talk about the preventive factor, if it's only going to be 44% versus 90%, now you're having a different conversation, because the risk of the patient really matters for the primary teeth. I do sealants on primary teeth in my office, and I think you should too. If the tooth is at risk and has a ICDAS code 1 through 3, I think that should be your first choice. That's the best thing for the patient. I'll show you one where it was a 4 today, and the patient's been 3 years with a sealant instead of a filling, and it's working out. I'll show you that later. Just remember that these teeth erupting sometimes are hypoplastic, and that's a difficult situation, and they're erupting, and we want to provide the patient with the best outcome. And sometimes it's best in these situations where you see here on the lower right to use a GI sealant if it's at risk. Probably this tooth for me, I probably would not be one to jump on that right now. But if that's got some stain, it's got a start of a cavity or hypoplastic, I may put that on to get me by and preserve that tooth until I can provide further evaluation. And it's really hard for these kids also to keep these teeth clean, as you'll see in this next slide. This is a poster that I have in my office. I would love to share this with you. I learned this from Dr. Roger Lucas. It's our sticky snacks poster. A lot of parents don't realize what their kids are eating and what's causing the cavities. So if we look at these surfaces and these occlusal pits and fissures and buccal and lingual pits and fissures that can benefit from sealants, these kids are eating cookies, they're eating dried fruit, crackers, chips, cereal, fruit snacks. And I'll say to you, in dental school, I wasn't really educated on the crackers and chips. Crackers and chip, I think Dr. Roger Lucas, I think it's 9 times stickier than bread. Don't quote me on that. But we know that amylase in saliva breaks down starch into sugar. And if they're eating this and it's sitting there all day on these occlusal surfaces and the interproximal surfaces, that can cause damage to the tooth. And people think they're having a healthy snack, and it's really not. It's not a healthy snack. We have a snack guide that we hand out. I'd love to share all that with you if you want to get in contact with me. If you want this poster, you can customize it for your office. I'm happy to give you that as well. But it changes the conversation when this is all up on the wall and you ask, what's diet? Diet plays a huge role in dental decay. People think it's just brushing and flossing. It's diet as well. And then also some of our factors genetically too, and our saliva and our mineralization of our teeth. That's important to consider as well. So don't ignore that. Don't brush it aside because everyone's at a different risk for decay. The longevity of sealants, caries reduction at 1 year is 86%, which is great. And at 4 years, we're at 58% of the teeth we seal from the data. And I think that's great. I think you can get better than that. And I'm going to show you the data from my office here. But I want to move into the AAPD guidelines. So the history of this is dental sealants have been around for decades. We know they work. We know they prevent food impaction. We now know that you can seal over decay and prevent the decay from growing. That's an amazing thing. And that's why I said we're going to move forward with the medical model. It's going to be tough. I think it really will. In 2008, the ADA Council on Scientific Affairs published a great paper. I love this paper. It's not all true today because we have more evidence, but it will shed some light on that, go through what's going on with sealants, and then move into our current day evidence in 2016. And what was taught in 2008 is not true today. And so keep an open mind as we move forward this with new things coming out, like silver diamine fluoride. I'm going to shed some light onto the evidence for that. Maybe that can replace sealants. Maybe Curidon. I don't know what's going to work best for our patients, but I want to present to you the best evidence tonight. And we're going to start off by moving forward with the ADA 2008 recommendations. I will look at those studies a little bit, share with you some information with that, because I think it starts the conversation and it doesn't finalize it. And I don't think we're done because I think the water is really murky in this. This first one, placement, these are their recommendations from the paper. So they're broken down based on their level of recommendation. And I've just highlighted some of the words here that I wanted to maybe make an impact with you tonight. And the placement of resin-based sealants is effective for caries reduction. This has been shown study after study. And this is why insurance will cover sealants on these permanent molars in kids. This came through from the evaluation on preventive services and reviews of evidence for dental caries, oropharyngeal cancer, and sports-related injuries. And it's really important to keep this in mind. Do I seal every tooth at my office? No. That's important to keep in mind. And I'll hopefully shed some light onto that on what I do seal, but it's important for you to realize that maybe we're underutilizing sealants because of some of the myths that are out there, and we can dispel some of those, I think, here tonight. So the reduction of caries incidence in children and adolescents, which is mainly what this been studies on, ranges from 86% at 1 year to 78% at 2 years and 58% at 4 years. And I think that's a good thing. We have these young kids where you may have that kid that's high caries risk, has had a bunch of crowns, and maybe a sealant's something to get them by through that challenge when they're an adolescent. I know when I was an adolescent, I was not a big kid on brushing my teeth. And I know I had sealants, and I probably benefited from that, from my parents doing that for me, because I don't have an occlusal restoration on any of my posterior teeth. I do have some other restorations, but that's a different story. But these sealants probably have prevented me from needing dental work in my life. And if you can offer that to your patients and provide them a benefit and not have to work on a young squirmy kid, I think that is a great thing. We all want to avoid this. Gosh, this is a 6-year molar in a young kid. You can see the primary teeth still there. That probably could have been prevented or delayed from a sealant. Sealants are effective in reducing decay in permanent molars in children with a reduction rate of 76% at 4 years in this study. And when reapplied, the reduction was at 65% in 9 years. What we do at my office is we'll usually apply the sealant on the 6-year molar, and then if they need it reapplied when we're doing the 12-year molar, we'll do that at no cost. So we can reapply that if need be. And it's something also that parents and patients need to understand, that the average lifespans, we tell them they wear out when we have the initial conversation. We're going to place a sealant. This typically, the research shows this will last about 2 to 3 years. And when it needs to be reapplied, they understand that. And it's not like you're a failure. It's like we prevented a cavity on this tooth for 2 years. That's a great thing for your kid. If you look at rate of tooth loss after a restoration, and I mean, we look at a restoration, maybe if it's a good one, lasts 5 to 7 years, then you need another one. I mean, that prolongs the tooth life for these individuals and our kids. If we look at primary teeth, insurance doesn't cover this, but I do it. Just because insurance doesn't cover it doesn't mean you shouldn't offer the service. You should. If you believe in the sealant on the tooth, I believe in them. I would much rather put a sealant on the tooth, and if they're a 3 or 4 year old and you delay that for 4 or 5 years, or 3 years in this case, and you don't have to do restoration, what did you just do to their behavior management? You changed it maybe from a Hall crown or sedation into something you can manage at the office. Is that something that is worth the 50, 60 bucks the parents spending on it? I think so. I think it's worth it. And I think they can last a really long time. And I'll show you the data. I will show you data from my office, I promise you. But at primary molars, anywhere from 74 to 96% at 1 year, and 70 to 65% in the other study, the second study. This was again from a study published in JADA, and limited sample size, 52 teeth in this study. But we should consider this. I think it's the right thing for our patients to do. And I've done it at my office. I don't seal every primary tooth. Medicaid in Iowa covers it. I don't do that. I seal the teeth like the ones on the screen that are at risk, that have stain, incipient lesions, ICD-10 code 1 through 3, and we have great success with that. We really do in delaying treatment for these teeth. Your insurance payers know this. I don't know if you are aware of some of the things that are going on with artificial intelligence, but we need to be aware of this as a profession. This is going to change the way you're paid. I truly believe it. I see it coming, and they have the claims data. They're going to start looking at x-rays. The AI is going to be able to determine the x-ray, determine the best treatment for the patient. While that may take away patient autonomy, I think we need to have a fight for that, for ethics. But this is going to be a challenge. But we can see that sealant placement on first and second molars in children and adolescents is a reduction in subsequent restorative services. So that's a good thing for our patients. It's a good thing for dental insurance, right? And I think that's why they pay for sealants on these teeth, because we're seeing a reduction in services, so they don't have to pay out. So would they rather pay a lower fee on a sealant than pay a restorative fee? I think so. Would you rather have to do that as well? I would love that for my patients. I don't want to have to do a class 1 filling on a 6-year-old that's not cooperative. I would much rather do something that's a preventive measure, like a sealant. We see again, placement of pit and fissure sealant significantly reduces the percentage of non-cavitated caries lesions for as long as 5 years after the sealant placement compared to unsealed teeth. That's a big deal. And we're ignoring this by not placing them on our patient populations or not advocating for them. Again, with Medicaid, for kids that were enrolled for 4 years, they looked at this. Sealed permanent molars are less likely to receive restorative treatment. And the time between receiving restorative treatment is greater, and restorations were less extensive. That's a win for your patients. So you should be a strong believer in whatever type of sealant you have. There's different times you can place them. I don't seal every single tooth at my office. I don't. I seal the kids that are at risk. I seal the kids that have been in the hospital before and have had poor hygiene, but I don't seal every single tooth because I am a little more conservative. I think given my lecture tonight and look at the evidence, I probably should seal more than I do, but I just feel that at-risk kids are the most important for me to take care of, and I wish I had a hygienist to help me out. If any of you know any of them, I'd love you to send my way. There's also no findings that there was an increase in bacteria under sealants when placed. We get a 100-fold reduction and a 50% cut in the viable bacteria. I think that's consistent with what we're seeing with indirect pulp therapy. That's nothing really new. I mean, if you don't eat, you die, right? And if the bacteria can't get that fermentable substrate, the carbohydrate, the crackers, chips, the sugar, then it's going to arrest the decay. And that's part of the medical management of caries that we need to consider. Now, that needs to be monitored. It's not like traditional dentistry where you place the filling and it's done. What happens when that sealant's lost? How can we increase the time until that sealant's lost? What if that patient never shows up in your chair? What if they're gone and they don't come back for 4 years and then the sealant's lost and you seal over decay? These are considerations we need to consider as a profession. I will say here, things have changed a little bit from 2008. So results in 2 of the 3 studies they looked at in 2008 showed that resin sealants are more effective at 24 and 44 months than glass ionomer sealants on permanent teeth in children and adolescents. And that's not where we are with our current evidence. We're actually showing trends the other way, but not enough to move the dial. And more research is going to need to be done. There's limited and conflicting evidence that glass ionomer sealants reduce caries incidence in permanent teeth. That is changed since 2008. Evidence is still low. Again, this is what I use at my office for the majority of the time, and I'll show you my data in a few slides here. There's limited and conclusive evidence in favor of using air abrasion as a cleaning method. So this study looked at retention rates when they did acid etch and then also did the air abrasion. They found just at 6 months, there was no difference between the etch and the air abrasion. But when you got to 12 months, it was statistically significant I'm sorry, I misspoke, 24 months. It was statistically significant that the air abrasion lasted longer than those that were just acid etched. So you may want to consider this as just one study. It's not, I guess, the Bible, but low evidence. But you may want to consider, if they're cooperative and you're doing a resin-based sealant, you may want to consider air abrasion in part of your protocol. If you look at air abrasion instead of etching, we're going to see that you're going to have a better bond when you etch and air abrade than when you just use air abrasion. Air abrasion is not to be a replacement for etching. And both the 2 studies that this ADA article cited, it was mainly, the loss was mainly on the buccal and lingual surfaces that were sealed compared to the occlusal. They did find that there was a better retention rate with air abrasion alone on the occlusal, but not on the buccal and lingual surfaces. So there may be some different changes in that allow for that. I typically would say that the buccal and lingual surfaces are harder to seal anyways, but keep that in mind if you're looking at air abrasion. I would consider etching as well. There's limited and conflicting evidence that mechanical preparation with a burr results in higher retention rate. You will see the studies showing that if you do like a PRR or mechanical preparation, you will maybe have a better retention factor. And I am of the point where I want to be the most conservative for the patient. And I know once we put a burr on the tooth and do a mechanical intervention that there's a restorative material there, and there's a chance that that's going to need to be replaced over time. I would much rather redo a sealant than have more tooth structure removed, in my mind. And that's my opinion only. So I can only speak to that, but I typically don't do mechanical preparation. I'm not a PRR guy or preventive restoration guy. I'm either a sealant over decay or incipient decay, or going ahead and doing a restoration. And a lot of that depends on the patient and behavior and where they're at. There's indirect evidence that the use of four-handed dentistry is associated with improved sealant retention rate. So this was a systematic review that looked at 36 studies and 11 were included. And we got a 9% increase in retention rates in four-handed dentistry. And is 9% a big deal? I don't know. That's something you have to decide, but typically having someone else to help you can really make a difference. And I think this probably comes more into line when you're looking at placing a resin-based sealant or compomer or an RMGI. We have seen evidence that multiple steps, moisture control is important. So if you're going to be placing one of those, I would highly recommend you have someone there to help you. If you're out in a mission trip, maybe a GI sealant is going to be better for that patient because you have better material properties for those kids. Sealant retention can be improved if the clinician applies a bonding agent that contains both primer and adhesive. So you're going to include, if you have a bonding agent that has primer and adhesive in it, you're going to have a better retention rate for half of the sealants that are placed on the occlusal surface, and then a third for the buccal or lingual. So if you're using a resin-based sealant and you have a cooperative kid, I would highly recommend that you do use a bonding agent. And more specifically, if you get into these lesions that have any white spots, brown, incipient, non-cavitated lesions, there is now specific evidence out there that you're going to have increased retention when you use the bonding agent. So keep that in mind when you're looking at some of these kids. I would highly recommend, if you're using a resin-based sealant, that you etch and bond. That's what I see with the evidence, especially if there's any question if there's a discoloration of the tooth or all. I think you're going to have a better outcome based on what we see with the evidence. Presently available self-bonding agents, like a single bonding, like if you have a universal adhesive, this was in 2008, provide comparable or less retention compared to ones that have a separate etching step. This is back in 2008. So if you look at the study they looked at, they found about 77% success with the different types in the different groups they found. So it wasn't anything that really changed things too much, but you may want to consider that. I don't know if there's been a new study on this recently that can change the way we think about it, but I would recommend that you do go ahead and do the etch and then use one with a prime and bond in it, and that will give you better results from the studies that I've seen, especially when, like I said, when dealing with teeth that have maybe a little more breakdown. This was a study here, and I think this is one of the big myths, that sealants don't work. A tooth with a sealant is gonna go ahead and make the tooth more susceptible to decay. That's false. So this looked at caries risk in formerly sealed teeth in 2009. This is after the 2008 study. And they looked at the risk ratio of sealing a tooth versus not sealing a tooth in the same mouth. And they found at 1 year, the sealed teeth were not, it's not a big statistical difference, but they were less likely to have a restoration. In the later years, again, 0.9. They're not at a higher risk. The risk ratio suggests that fully sealed teeth with partially or lost sealant were not at a high risk for developing caries compared with non-sealed teeth. So there's a right way to do the sealants. I agree there are bad sealants, but it's not going to increase the risk for the tooth in these situations. So that's a myth. I think if you want to seal tooth, you should seal it. Like, it can be a benefit to your patient. All the evidence that I present tonight shows delayed time to restoration and no higher risk. So this can be a great thing for your patients and a great preventative measure, especially in primary teeth, which, you know, we talked about earlier. When I look at sealants in my office, this is what I look at. I look at the International Caries Detection model. And typically, if it's a 0, a sound tooth, a low risk kid, they haven't been to OR, they haven't had decay in their primary teeth, that's not something I'm jumping into. I mean, the patient could benefit based on the evidence I presented tonight, but most of the time I'm waiting until we have a high risk kid that's been to the OR and that tooth comes in. If that's a high risk kid and it's sound, yeah, I'm gonna seal the tooth. They have a history of decay. We know the biggest predictor of future decay is prior decay, and that patient can have a benefit. But if they're a low risk kid with no decay, I'm gonna wait and use that benefit for their insurance when they have the code 1 or the code 2 or the first visual change in enamel. And you can even get to these ones where they're stage 3 and you start to see that change a little bit. And that's one that's a little more on the edge for me. You can still seal that. You can seal a 4. I don't seal 4s. I do restorations on 4 unless the patient's uncooperative. But you can seal a 4 and you can seal a 3. So if you look at 1 through 3 codes sealed, 100% higher probability of not having a restoration. I mean, it's going to be compared to not sealing it. You're going to have higher sealant loss as well on these if you're not bonding them. And reapplication is going to be more necessary if you're sealing 1, 2, and 3. If we look at the use of bonding agents here in these, we're going to have statistical significance, 83% retention versus 53% if you're not bonding. And that's for cavitated ones, so like a 1, 2, or 3. And I would highly consider that if you're using a resin-based system to bond your sealants on the 1, 2, and 3, and even on the 0 if you're doing that on a high-risk kid. This is a kid that this is my last patient of the day. I don't know. Every time I give a lecture, there's always a patient that walks in and it's like the perfect one to see. So this is a patient that came in. This is a primary dentition. So tooth A has large cavitation. We have a small cavitation on B, and also here on T, we have a small cavitation. We treated A, it was a little bit bigger. I treated that with a Hall crown, and I just did Riva Self-Cure HV, the sealant product I use, on these other 2. And this is 3 years later. She walked in today. You can see my sealant material, the Riva Self-Cure. There's not much change. We got a new incipient lesion on the distal T. The Hall crown worked great. The sealants worked great, and that was 3 years ago. And all I did was place a glass ionomer on that kid knee to knee, and she wasn't happy. She's better now, but she wasn't happy. And sealants can do a great thing for your patients. I can tell you of kids that have come in uncooperative, and all they've got is 1 6-year molar, and it's hypoplastic, and they're not cooperative, and we get them to the point where we place maybe SDF, maybe just the sealant, depending on what the parent is, and we move them 2 years, 3 years down the road, the lesion doesn't grow, and now I can restore that conventionally. And that is a great way to take care of a lot of these kids that we have at our offices, because we know that sedation, access to care is challenging, and that's not what everyone wants to jump into. So sealants, what can we seal? So maybe look at a sound tooth structure. Absolutely, you can go ahead and seal that. I reserve that for the highest risk kids at my office. Here's an incipient lesion on this premolar here, where it's in the outer shell of enamel. I would definitely place a sealant on that at my office. Here is one where it's deeper. That's going to be a sealant at my office. one that's barely outside of enamel, that's a sealant. And then probably, unless they're not cooperative, I'm probably going to restore this one conventionally. And a lot of times, I know radiographs are not required for sealants, but a lot of times, if I'm questionable, I'll compare my radiographic image. And if it's not visible on the radiograph, I know they're bigger than they are on the radiograph, but I typically will be more conservative and place the sealant versus a restoration unless I can see it visibly on the radiograph. Options for these teeth, when we move forward, this is actually my tooth here in this picture. This is an incipient arrested lesion, and your options for this tooth are to do active surveillance or fluoride varnishes. Probably not as good as sealants. You could do a sealant. You could do a resting protocol such as SDF. You consider Curodont or a new protein peptide on this tooth, and you also could consider resin infiltration. Probably at my office right now, what I did for my own tooth was a sealant on my own tooth, but that's what I'd probably recommend for if this were in one of the kids in my office's mouth right now. Other factors to consider are behavior. If they're not cooperative, you probably don't want to be trying to do acid etch, bond, air abrasion, the whole 9 yards. If they're low caries risk, they may not get as big of a benefit. If their oral hygiene is not good, that may be something you want to consider as well in incorporation with the caries risk. If they're not brushing well and they're that teen that never does it, maybe you seal that tooth versus not on a sound tooth structure, even if they're not really prone to having a ton of decay in the past, because your caries risk can change over time. Access to routine dental care. If I have that patient, God forbid, they're in my office only every 2 to 4 years, that's probably someone I should place a sealant on, right? If they're not getting routine care and getting reevaluation, I should probably place a sealant on those kids with these incipient lesions. They're going to get a huge benefit. We can move into now materials here as we keep going. Resin-based sealants, GI, comprimers, resin-modified RMGIs, and STF's not a sealant material, but you can use it as a preventive measure. So resin-based sealants, here you can see on the right, they're bonded with acid etch, and they can be filled or unfilled, which we'll get into here in a few slides. They're light cured, so it's going to take a little bit more time. Glass ionomers form a direct chemical bond to the dentin and enamel, and they actually do recharge with fluoride. And the great thing is you can place them on these wiggly young kids. They are moisture tolerant. You don't have to have a perfect isolation like you do for your resin to work out. So that can be a benefit as well. Resin-based sealants advantages, they're a little more aesthetic with the color. You can actually clear ones, you can get opaque ones. They're a lot more wear resistant. They are bonded, they are filled and unfilled, so you can actually have a great amount of wear resistance compared to glass ionomer. If we look at glass ionomer sealants failing, they fail from wear. Resin-based sealants fail from micro leakage. Disadvantages, you have to have a cooperative kid. You have to have lots of steps, and they leak. This is not as good of a bond. So there's two types. You have filled and unfilled. The unfilled are lower viscosity. They're going to say that really moves into the grooves better. They self-adjust. I would still check the bite if you're doing a resin-based sealant that's unfilled. The filled have a higher filler component. They're going to be better wear resistance, better bond strength, and you're going to have to adjust the occlusion on these sealants. The color can change, so some people like opaque so they can see if it's there. There are studies showing that if you use opaque sealant versus a clear sealant, you're going to be redoing more, which I think makes sense because you can actually see where it's gone versus not. The clear has an advantage, some people think, because you can see the changes in the progression of the lesion underneath it if it's leaking. And then you can also get tooth shade. Placement for these, at minimum, if you're doing sealants, you should be doing a toothbrush prophy, at minimum. That should be to get the debris, the food out, and ideally you do a prophylaxis and clean out the grooves really well. You may want to air braid if that's your style. If you've got that at your office, we've shown evidence that it may increase retention. Isolation's key. I would highly recommend, if you're doing these resin-based sealants, to at least at minimum use an isolated rubber dam. It's been shown that we need to have good material properties for bonding and etching. And if you don't have time to do it right, when do you have time to do it over? I'd etch and then apply prime and bond and light cure and then apply the sealant. So those are the steps here. And at my office, if I'm going to do a resin-based sealant, if I can't get an isolite in, I'm probably going to do a glass ionomer sealant instead. Just my opinion. GI sealants, these are kind of, I think, coming now to be more popular. I think we're seeing a lot more pediatric dentists doing this because they're moisture tolerant, they're quick, it doesn't take time. I can do this at my recall. It's a chemical bond, we get fluoride recharge. They are a little more expensive, you're spending more than your composite, but I would much rather spend a little bit more and not have to work on the tooth for my patients. They do wear out and they are not as durable. So you can typically use these on those teeth that are coming in. They're uncooperative kids. I can do these knee to knee with the product I'm using now. I know with COVID, we had concerns about aerosols. That's not as much of a concern now as we move post-COVID. You can use the Riva Protect here. I don't use this one at my office. This is their sealant material that they promote from SDI. It's pink. You can use this for indirect pulp therapy to let people know that you left decay. And you can also use it to check and see if your sealant's there, like the opaque ones. They also make a white one. They have a fast and a regular set. I would recommend that you use their regular set if you're doing multiple teeth. And they can really be used in a lot of ways here too. This material can be used. I prefer the Riva Self-Cure HV. Here you can see compared to Triage, both these products, great. If you're using Triage, great. If you want to look at Riva Protect here, you're going to get higher fluoride release here over time. And that's why these sealants also are beneficial from a glass ionomer standpoint, because the resin ones just, they don't do that. They're self-adhesive. You don't have to do all those steps of bonding. And like I said earlier, if you have a kid that's knee to knee and they're a 2-year-old and you want to seal a small spot on tooth number T that just came in and they got a spot on it, that's great. I think that's a great service for the patient. You can also use different fast or long sets. So here you can see, especially on these young kids, you may want to use a product that sets fast. So the fast set on maybe beneficial on a 2-year-old or a 3-year-old, versus if you have a 6-year-old and you have time to go ahead and isolate, you may want to go with something that's like a regular set or a Fuji Triage. They can usually do about 3 to 4 molars here. And I would say if you're doing multiple quadrants, you want to use a regular set. You'll get frustrated here. And here's again the example of using something as a liner. If you're doing a lot of indirect pulp therapy, this is going to show up radiographically. What happens when they leave your office and there's a radiolucency under the restoration? They open that up, that white restoration there on the right, open that up, and now they see pink. It's going to be a sign to them that maybe something was left here, maybe decay was left. Again, clean the tooth with the toothbrush, apply the sealant. I usually use my finger with either saliva or water, and a cotton tip applicator can be used as well. Here you can see just a demo here. I don't know if this is playing on your screen or not. Kevin, is it playing or not?
Yeah, it's playing. We're good.
Okay, so pause. So just go ahead and apply it a small amount, and then if you use something that's wet, you can wipe it off. And it's so simple. This is what I do with the Riva Self-Cure HV. And if you have a dry handle, stick to it. If it's wet, it won't. You can use an instrument to go back in and finish. And you can really do a nice result in a quick amount of time without having to worry about etching, bonding, isolation. So again, this is the product I'm using at my office. I use this instead of the Triage because of the viscosity. It's thick, and on these young kids, it sticks where I put it. And it is an amazing product. I wouldn't tell you that if I didn't believe in it. So the Riva Self-Cure doesn't have the micro leakage here. You can see long-term micro leakage with the Riva Self-Cure. Riva Self-Cure HV is what I like, the thicker one. Cumulative fluoride release, very similar again here to the Fuji products. And I use SDI because they're a little more cost effective, and I see a lot of Medicaid, and I want to do the best thing for these patients without breaking the bank. Very low acid erosion, and this stuff gets rock hard. Here's the data from my office that I'm promising you. So this is advancing caries rate, teeth that have been sealed after 1 year. I don't seal every tooth, so you're not gonna see a huge number here. I'm sealing the high-risk kids, the at-risk kids, which should make this data more compelling to you. But out of the sealants I placed at 1 year, over 400 sealants, we only have 6% getting a restoration. And that's in line with the data that I presented earlier with the research. If we move to 3 years, we're 87% caries free. And at 5 years, 85% of the teeth that I've sealed don't have a restoration. And that, for me, I was really nervous to install this from the ADA because it does your restorations, your endo, it puts you out there as a provider. And I was really nervous to do that, but it has made me a better clinician, and I'm really proud of the care we give our kids at our office. And this is all Riva Self-Cure HV sealants. I've been doing this for years, and I believe in it. And the success of a sealant is not if it's there or not. It's if the tooth is cavity free. And my teeth are cavity free for the most part. If you're getting a sealant in my office, yeah, I mean, at 5 years, if I can tell you I don't see it and it's 85% successful, that's something I can stand behind. RMGIs you can use as well. They do have more resin, so they're going to be less moisture tolerant, but they're going to have better wear properties. I tend to see these stain or discolor a little bit more. So consider that if you're looking for something more aesthetic. I think the GI or the composite may be a good option. SDFs kind of come on the market here. We have evidence to show that this can arrest decay even without placing anything over it. So if you look at the data here with the Riva Star, you can see both advantage arrest and the Riva Star. You're going to see a 93% to 90% arrest rate at 30 months in this. So if you're not a big fan of placing material in there, maybe this is something you use. It's go ahead and place the SDF and deal with maybe some discoloration and have that arrest decay so you can reevaluate it. I mean, it's not going to look the best, but if you're not a big fan of sealants, it may be another option. If you look again at the AAPD's data, the studies they looked at, 24 months, 68% arrest rate, 70. This is similar to the data that we're talking about sealants. So this could be an alternative for some people. And by all means, if you have these uncooperative kids and you're not wanting to spend a lot of money on the glass ionomer, why not just use the first step, the Riva Star Aqua, the first bottle on these kids? They already got a dark stain. Why not put that on there and at least have a chance at getting to the point here where you're at 70 or 80% and you buy yourself some time to get to that point where you have a cooperative kid. And I can tell you can apply SDF very easily and you do it quickly and not have to worry about it. Put it in with the varnish and put it on the tooth. And that can give you a great outcome for these kids. You can see greater penetration here of fluoride depth with the second step. That always is not something that I apply. You got to apply it for 90 seconds to reduce staining. And if you have a kid that's wiggly, that isn't going to happen. I'll tell you that right now. Again, here you can see if you're using the two-step with the second step, you're going to get a higher uptake of fluoride. And that's just because you're precipitating out the silver. And it's going to get a better uptake of your fluoride to hopefully give you more penetration. You're also not going to have as big of a depth of penetration as the silver. So that's something to consider as well. Incorrect application of Riva Star Aqua, it will sting the tooth. This will darken the tooth. Again, here, this is just a time-lapse video between the two overnight that I set up at my office. You can see advantage arrest on your right side and the Riva Star on the left. You can definitely appreciate a different outcome. So if you're not a big fan of sealants, this may be something you look into. Again, that second step of the KI, you're going to need to apply that for 90 seconds per tooth and apply that to anywhere there's a white spot. So keep that in mind if that's what you want to go. And it will stain any area next to the tooth that's got an incipient lesion. So I don't want to tell you not to do it, but make sure you use it judiciously. And this is the new code that you can use for the SDF, caries arresting medicament per tooth, to go ahead and place that and have success. This is a case I wanted to show you with earlier. This is a kid that came in with decay on a 6-year molar, not cooperative. I mean, I barely got these photos on the first visit just to show the parent. And we went ahead and did SDF and then placed a GI. And we were able to come back and restore these teeth conventionally. And that's a great thing. We didn't have to use sedation for this kid. And that's a great way to use SDF and a sealant and have a great outcome. I think we should be doing more of this in cases that don't have huge needs. Isolation consider cotton roll or dry angle. I'm not a big fan of this unless you're doing GI sealants. It's easy to do, but it's kind of, when you're dealing with all these steps on these resin ones, I think it's a shortcut. Not what I would probably pick for my kid, not for my mouth. If I can't get good isolation with a rubber dam or isolate, I'm probably going to go ahead and place a glass ionomer. Again, rubber dam is a great standard care for restorative dentistry. The problem with this is, I mean, I had one placed in dental school with a rubber dam. I had to get numbed for it, which was one of the problems, but it really does allow you to have great material properties. I'm a big fan of this for resin sealants. When I was doing all resin sealants, this was huge for me. Isolite or iso dry. Protects the airway and sedation especially. It's got better isolation than cotton roll. It does cost a little bit more, and some kids you can't get it in, but it is a game changer for restorative dentistry. This is an awesome product, these products are, and to be able to isolate and have ideal properties for your restorative material, not have to deal with anesthesia on the teeth to do sealants. Moving into the APD from 2016 here, you can see things have changed a little bit. So they ask a few key questions. There are 4 key questions. Should dental sealants compared to the non-use be used on these teeth? And the evidence is here. So they looked at 2 to 3 years out. This was a randomized controlled clinical trial with 9 studies. And they said, yes, 76% of the teeth that were sealed at 2 to 3 years were cavity free. And again, another study where they looked at sealants versus non-sealants, and 75% of the teeth were cavity free. The AAPD recommends the use of sealants compared with the non-use of sealants in primary and permanent teeth. And this is a strong recommendation with moderate quality evidence. And I think that's something that we should consider for our patients. Should dental sealants, when compared with fluoride varnishes, be used? Well, they looked at 3 studies here at 2 to 3 years, and yes, sealants outperform fluoride varnish by 73%. The guidelines suggest that the use of sealants compared to fluoride varnish is beneficial. And this is more of a conditional recommendation. We don't have as much evidence, but it's better to do the sealant than to put them on active surveillance. And I think that should be something you consider for your adult patients as well. Which type of sealant material is better? Well, this was a lot to unpack because there is just, it's all over the board. So if you look at resin versus a GI may reduce the incidence of occlusal decay by 36% at 2 to 3 years. And this is 10 studies. This was not going to move the dial. We don't have a p-value here that's statistically significant. Again, resin versus GI and non-cavitated caries again, 53% reduction, but it didn't have the numbers to make it a difference. They did note that GI sealants were 5 times more likely to debond. Well, yeah, I think that makes sense. They wear more. We went over the evidence on the materials on that. But what's the outcome? That you're cavity free or that the sealant is there? For me, it's that you're cavity free. GI versus RMGI. GI compared to RMGI may increase. Now we're going the opposite way, increase the incidence of occlusal decay. And GI sealants are again more likely to debond at 2 to 3 years. So we have a 41% increase in what the APD looked at here compared to the GI, which is the opposite of where we were with GI and composite. Now RMGI compared to Compomer, it may reduce by 56% at 3 years, but we're only about 1.7 times more likely to have that debond. So now we're getting into more of the resin-based products. And then we're going to go the other way. So Compomer versus resin. So Compomer compared to resin sealants may increase, again, the incidence of occlusal decay. These are all not, they don't have a statistical significance. Resin sealants are more likely to 13% more likely to be lost at 2 to 3 years. So the panel was unable to determine the superiority of one type of sealant over another. And this is where it takes your clinical judgment to come in and find out what is going to be the best for your patient. Consider isolation, consider caries risk. I mean, if you have that 6-year-old that can't sit for isolation, maybe do the GI. If you've got a 12-year-old that can sit for everything and you want to bond and etch and air braid and maybe consider mechanical retention, by all means do it. But you have to make the decision. There's not one thing here that I can tell you tonight that is going to work for every single patient. And that's okay. It's great to have different products in your office. It's great to use different materials, different techniques, and adapt that to the patient and give them the most positive experience that you can have as a dentist so that they grow up to love coming to us. I think building relationships with our patients is one of the most favorite things I do. I showed you that patient that I showed you the GI sealant on the caries. And that patient was not fun to deal with. And now she loves coming to see us. And that's because I treated her with compassion and care. And you can do that at your office as well. Okay, any adverse evidence as we wrap up associated with use of Pit-and-Fissure sealants? There's BPA in some of these. There's no evidence that this transient amount has an impact. And again, fully or partially lost sealants do not pose a greater risk to teeth that have never been sealed. So that's a big myth tonight that I want you to take home. I think these school-based programs have a place. Not everyone can afford to go to the dentist. Not everyone wants to go to the dentist. And maybe if that kid gets that sealant at school and that prevents them from needing to come see me on emergency, maybe that's a benefit. A few things wrapping up tonight. I do own pediatric dental seminars. We have a seminar coming up in July on the 7th. This is a comprehensive pediatric dentistry course. Here's a QR code for it. For attending tonight, if you want to use the code PDS50, you can get $50 off on that. We've had 2 great groups this year. It's been amazing to be able to teach a zirconia crown, stainless steel crowns, the Hall technique, minimally invasive dentistry. This is dentistry, soup to nuts. And this is one of the favorite things I do, is to make an impact on other providers so that they can do great things for kids, because there's only one of me, but each person that comes to my course can go ahead and make an impact, increase their production, and really treat kids in a way that is outstanding. And I really would hope to see you at one in the future if you don't want to attend this one. Again, tonight, SDI is giving you a 1+1 on the Riva Self Cure, Light Cure, the Riva Aqua, their SDF, or their Riva Protect, or the Riva Conceal F and Conceal. I, again, use Riva Self Cure HV for my sealants. If you want to redeem this offer, go ahead and purchase it from your distributor, and then email here invoices at usa.canada@sdi.com.au. You'll get your free goods. They're very good about following up on that. I will send this out again here in an email just to remind you as well. And wrapping up here, Kevin is going to come back on as we look for questions, but he's going to go over this last slide. They have a great promo here, $20 off any purchase by the end of the month. We really appreciate you doing that for the attendees, Kevin. And I really appreciate, we have a great group on tonight. So I would like to stick around if there's any questions. I'd be happy to answer those. I know we're right on time.
We're doing pretty good on time here. And just FYI, for those of you who may wish to take advantage of those offers, we will send out a link to the recording tomorrow to everybody, so that you can fast forward through the recording if you need to get the details on those offers. So no worries there. But you do need to, it'd be a great idea to screenshot this slide, because you need that code, WB623C as in cat. You need that code on your evaluation quiz to be able to submit it. So again, we'll be sending that out here as soon as we wrap up. And be sure to use that webinar at garrisondental.com email address for any problems with getting your CE. So Kendall, I see the question button is lit up, so I assume we have some questions there for Dr. Johnson tonight?
Yeah, so before we get into questions, the eval and quiz is linked in the chat window along with the code, and like Kevin mentioned, you do need that code. For the first question, what are your thoughts on the occlusal stamp technique?
Yeah, so I believe the occlusal stamp technique is taking a material and making an impression of the tooth beforehand, and then you can go ahead and do a nice restoration with that and be able to get back to the way the tooth really was in the beginning. I think for that technique, you're going to have some cooperation from your kids. I think if you've got some cooperation and you really want to get back to where their natural occlusion is, I think that's a great way to be able to push that resin out and really mold that and not have to do a ton of post-operative adjustments. So if you're using it at our office, great. And I think you can be very successful with it.
What is the best treatment for hypomineralized first molars?
That's a whole nother webinar to unpack. So I think it depends on where the kids are, what the prognosis is, where they're at with caries. I mean, I do not have a problem placing a stainless steel crown on them. I do not have a problem when they have decay, extracting them. And then I do not have a problem sealing them and seeing where the kid goes. So I think it depends on where the kid is in their journey and their cooperation, obviously, and their at-home care. There's not one way we can paint it for everyone. And that's what is a challenge for us as clinicians. So like that case I showed you earlier, that kid was able to work through their journey with me. Not everyone is. And, you know, there's some of the most wealthiest kids in town I've taken out their first molars. I'll tell you that. I mean, that's just where we were at the time. So it's not something that I can paint a pretty picture for you on one way all the time. And I typically will try to be conservative, but if I know it's not going to last the kid their lifetime, I'd rather take it out and let the second move forward. By all means, I do it all the time.
When reapplying sealant, do you repair or do you remove and replace?
So typically I'm doing glass ionomer sealants, so I'm not having to do a lot of repair. It's already pretty much gone if I'm reapplying the sealant. If it's partially, if I did a resin sealant, I did those in the past, I would go ahead and remove what was there before so I could see what's underneath it. I know they fail from micro leakage most typically, so I'll just go ahead and just take a quarter round burr, remove the old sealant, and then place a new one. But typically glass ionomer, and it's all gone, so you're just resealing.
When there is caries in the occlusal fissures / buccal pits, how do you decide to do a sealant or remove caries and restore?
That's a great question. So it depends a lot on your patient. So if you have a young kid and they're not cooperative, go ahead and consider, if you can, STF and a GI. That's going to buy the kid time. If they're cooperative and you know it's into dentin, I'm planning a restoration. I mean, that's just the way it is for me. It's not going to be something that I try to mess around with. That kid's going to need that tooth for their entire life. And maybe with these uncooperative ones, you do the SDF and the GI and you put them on a 3-month recall so you can reevaluate it, work on their hygiene, work on building a relationship. And I can't tell you how many kids I put on a 3-month recall and they flip the switch and we're able to restore it within a year or two. And the lesion didn't advance. I've got some kids in town that I've had SDF and GI on these permanent 6-year molars on carious lesions, and we're 3 years in now. And they're still not to the point where I want them to be, but we haven't had to put them to sleep. So it's been a great benefit to the patients to temporize, buy time, build relationships, and get to the point where you can do the conventional dentistry that you know and love.
When using a laser, would you bond and etch?
Ooh, I'm not familiar with it. So maybe the participants perhaps got a Celea or anything like that. I am not a big guy on lasers. I have a diode, but it's not something I'm familiar with. So I'd have to defer to someone that's more of an expert on that. I can't speak to that question. I can probably look at PubMed and get back to the participant. If you want to give me their email, I'd be happy to dig that out for them on etching and lasers and all that, but I'm not an expert on that, so I can't speak to that.
Do you like cure your bonding agent before sealant application or cure both at the same time?
So I would go based on the manufacturer's recommendation or the IFU. So typically follow that as you would any other product, and that would be because every product's different, every IFU is different, and I'd keep that in mind as you look at using your products.
Does Curodont work on all surfaces?
So the most evidence I've seen with the Curodont has been with recently the APD just put out this article and the guidelines, and not guidelines, but their journal, and it was on white spot lesions. So that's been the first evidence that I've seen. I'd like to see more. I had the rep in my office. We talked about interproximal application. I know that's not going to be, it's going to be like STF where it's not as ideal. So I think we're going to have to look at, as this technology develops, what the evidence shows works and doesn't work. And that was the same way with STF when it came out. I remember being a resident and graduating and STF was coming out. I thought I had $400,000 in debt and I didn't think I had a job because this is going to eliminate decay. And we know that's not the case. So I think there's ways we need to go about new products and evaluating things and keeping in mind that we have to learn how to use the products that are coming out. And I think Curodont's going to be one that my eye's on and that we can use, but I think we're gonna have to figure out the same thing with SDF. Does it work better on smooth surface or occlusal, or should we be placing a sealant over it? These are all questions that are gonna have to be answered. And I don't see the evidence out there right now to tell us one way or the other. So we'll have to keep an eye on that.
Under what circumstances would you place a sealant on an adult's permanent tooth?
Well, I put it on my tooth. So if they're at a high risk for decay, maybe if you got someone in a nursing home that's got decay and you don't want to drill on it and they're not going to be cooperative, maybe if they've got an incipient lesion. I mean, if you're an ICDS 1, 2, or 3, I would want a sealant on my tooth versus a filling. I'll tell you that any day, and I would pay for it. I'd pay the 60, 70 bucks, whatever you're going to charge me, versus having to have my tooth drilled into. I mean, I think most of your patients would rather accept the sealant versus having to have work done. I mean, that's not always the most fun thing for adults to go through.
If you decided to air abrade and acid etch, would you acid etch first?
I'd have to go back and look at the 3 studies tonight to see what they did first. I don't recall.
Are stained fissures indication for sealants?
I think so. I mean, that's an incipient arrested lesion if it's black or brown, or if it's like a light yellow, it's active. So I would say that should be something that you should consider a sealant on, unless maybe you're one of those SDF fans where it's stained from the black of the SDF and you're not a big sealant fan because you heard all the myths about sealants versus non-sealant and the increase for decay, which is not true, which we dispelled tonight. But I mean, if you want to be able to evaluate things, maybe the SDF is something you consider, maybe the sealant. I would want my tooth sealed. I showed you my tooth tonight, it's sealed. That's what I would want for me.
Going back to an earlier answer you gave, did you say no caries removal before placing GI on an adult tooth?
Depending what your goal is. So, I mean, if you're doing like a temporary restoration, I mean, no. If you have a healthy adult like me, and I've got a cavity at ICDS 3 or an ICDS 4, I would remove the decay and place a filling. Like, I'm cooperative, I can get through that. I think the water gets murky when you start putting everyone into one bucket. And yes, maybe you have that older adult where they're not going to be around forever and you want to do the GI without caries removal. Maybe you have that patient that comes in pain and you don't have time to treat them that day and you know it's reversible vulpitis, put in the GI and then come back into the filling. Maybe you have the uncooperative kid in your chair that's going to get by with the temporary filling and you can reevaluate that. I can't give 100% of the answers for all the time. There's different situations, and that's where I think there's beauty in how you be compassionate in treating your patients, because if I were to just say we're going to do this one way all the time, I probably wouldn't have any patients. I wouldn't have any patience for my patients because I'd get frustrated. So if you're going to be doing it for a temporary restoration, by all means, you don't have to remove decay. If you're going to be doing it in older or younger kids just to buy time, by all means, don't remove decay. If you're going to be doing something to be long-term, then I would probably want to have either selective caries removal or majority of the decay removed before the placement of the GI.
Any evidence that a small amount of GI is retained in the deepest part of occlusal grooves, even if the sealant is no longer visually detectable?
I've heard from other KOLs that there is evidence. I don't have them off the top of my head, so I'm not going to speak specifically to that, but I want to speak back to some of the things we talked about in the lecture, which is fluoride release. So the GI is actually going to be able to recharge and have fluoride come back into it. So you're going to be forming hydroxyfluoroapatite versus not. And I think that's one of the reasons why, even though my sealants aren't all retained, I'll tell you that, I think that's why I'm, upwards of 80% at 5 years with my sealants, is because the fluoride uptake's hardening the tooth. And we know that if the fluoride comes in, you can't have the hydroxyl ion come out when there's an acid attack. I truly believe that, plus the high viscosity of the Riva Self-Cure HV, is why this product works so well in my hands, is because it stays where I put it. I was using the Riva Protect for a little bit, and they'd come back and they're all washed out. The Riva Self-Cure HV is not. And if that can stay there and recharge fluoride and make that tooth harder, I think that's a reason why I'm not seeing, my numbers are incredible, and I'm not here to brag. I'm just like, that's impressive. When at 5 years, you're better than the majority of the studies out there on sealants, I think that's impressive. And I think this product is impressive, and it's not hard to use. It's really a no-brainer.
Is it a necessary step to use a conditioner for sealants, or is it cooperation dependent?
Cooperation dependent. Ideally, you would want to etch or use a conditioner. You're going to get increased bond rates with the glass ionomer if you etch and condition. By all means, the studies support that. But like anything, you got to meet the patient where they are. And if they're not going to sit still, then by all means, I'd much rather compromise and not place it versus etch and place a conditioner and have that not go well for the patient.
This next question is going to be our last one, and if I didn't ask your question after consolidating them, for example, questions to review specific slides again, I just wanted to remind everyone that we will be sending out the recording tomorrow. So the last question is, do you think white two-step SDF products are as effective?
White two-step SDF. So you're referring to the Riva Star Aqua or the Riva Star, in this case is my assumption. I don't want to put words into anyone's mouth, but the studies have shown that there is no difference in arrest rates with the two-step versus Advantage Arrest. There's no difference in arrest rates. They've also shown in these long-term studies that there's no difference in staining or discoloration. And the one thing the studies don't put in their methods is how long they're applying the second step. Because I showed you that slide of the staining, and the first time I used the Riva Star Aqua, it stained the tooth, and I wasn't applying it for the longest period of time. So does the potassium iodide and the Riva Star stain over time? Or do people not apply it for long enough and it stains the tooth? I think that's a question that we'll have to learn a little bit more about with the literature. I have not seen the staining. 90 seconds is a long period of time for a kid to sit still. So keep that in mind. Right now, I'm just using the Riva Star Aqua, and if they're not cooperative, I'm just using the first step. And we accept the staining. And it's worked out great. I have the option to do both. In the cooperative kid with the adult tooth with indirect pulp therapy, I can go ahead and do the 90 seconds and sit there and apply it and have an aesthetic outcome. So I think we're going to learn more about that, but no, there is right now evidence shows no difference in arrest rates between the two in root caries, in placing it as indirect pulp therapy, and I'm sure we're going to have more studies come out. And if you want to learn more, I'm following this actively with Pediatric Dental Seminars. We have a study club, so I pick up 5 articles every month. We go through those. If you want to be involved in that, you can definitely join me on that platform, and that's another fun time to just look at the literature and the evidence and improve yourself, because that's what I'm all about, is improving myself too.
Yeah, and we
All right, that's it.
Yeah, we really appreciate Dr. Johnson, you joining us again here this evening. We've done, quite a few courses now over the years with Dr. Johnson, and have more planned for the future. So be looking for the email. If you didn't jump on the chat window and get your eval and quiz there, we will be sending out that the email shortly. And then tomorrow, Dr. Johnson will be sure to send you a copy of the link to the recording and everything as well. So we'll get that out pretty, probably 8, 9 o'clock tomorrow morning. We'll be sending that stuff out. So, so thank you once again, Dr. Johnson. Thank you everybody who tuned in. There's still